We presented the analysis after prolonged follow-up of 6 years, where this is an international collaborative retrospective cohort study where we studied patients who were treated with fixed duration Bendamustine Rituximab and continuous duration Ibrutinib in the frontline setting for patients with Waldenström's. There we identified after 6 years that BR or Bendamustine Rituximab and Ibrutinib actually perform very similarly with respect to progression-free survival and overall survival. So there were no difference between PFS and OS in this patient cohort. All these patients were mid-88 L265P mutated, and we excluded patients who received Rituximab maintenance treatment. However, BR cohort had a deeper responses, so more VGPRs, more CRs compared to Ibrutinib group. Despite achieving the deeper responses, the progression-free survival were very similar. So as the overall survival. Importantly, the time to next therapy was different, where our median time to next therapy was not reached in patients who had received BR, versus the median time to next therapy was about 5.5 years, which was statistically significant in patients who received Ibrutinib. And after 6 years of follow-up, about 58% of patients were free from receiving the next line of therapy, patients who received BR, versus 48% of patients were free, patients who received Ibrutinib for receiving the next line of therapy. So that was statistically significant. Overall conclusion would be to actually, when it comes to selecting fixed duration chemoimmunotherapy, most preferred is Bendamustine Rituximab, because we have shown that, and others have shown as well, that BR is better than the DRCO-BDR with respect to time to event analysis, better PFS, better time to next therapy, and deeper responses. So BR for fixed duration, and most commonly studied, widely studied, commonly used globally is Ibrutinib for BTK inhibitors when it comes to selecting fixed duration BR versus continuous duration Ibrutinib. I would suggest efficacy-wise, almost it is similar. So go with the resources, availability of the drug, and most importantly, the adverse side effect. So the comfort level of the provider, comfort level of the patient, and also cater it for the adverse side effects for the patients. So that is my recommendation.